And good evening. Welcome to Recovering Hope. My name is Marcley, and once again, a pleasure to be here with you on this Wednesday evening in the Port City. We're here to do the best that we can to assure you, once again, that there is hope for those struggling with addiction. The parent company, if you will, of this podcast and radio program is Prodigal Recovery. Prodigal Recovery is a nonprofit business. If you would like to make a tax-deductible donation to help me continue to get the word out, or perhaps become a sponsor of this program, please let me know. You can go to recoveringhope.org or call 910-231-6020. Tonight we have a special guest, Dr. Eric Morse. Dr. Morse owns and operates, I think, about 8 clinics in the state of North Carolina. Perhaps we'll speak to him about opening one here in Wilmington. And is a specialist in what I would say medical-assisted treatment. We'll get to the nuts and bolts of that and just what that is and perhaps what that is not as we continue our conversation with, or should I say, as we begin our conversation with Dr. Morse. He spent a lot of time in this industry and has seen a lot over the years that they've been in business, and they've helped to, I believe, save the lives of countless people that have struggled with addiction. And we're going to do things a little bit differently this evening, whereas at the end of the program, we will be doing a recap of last week's show, because I want to respect Dr. Morse's time and get in as much information as we can there. So I don't want to hold him up. And from what I understand, we have Dr. Morse on the line. Are you there, Dr. Morse?
I am.
Well, thank you very much for your time. I know you're a busy man, and we want to get right to it. A little information on you and the business that you run there, Doc?
So I'm an addiction psychiatrist. I did my college and med school at Northwestern. Did residency in psychiatry at UNC in Chapel Hill. Mm-hmm. And at that point, I knew I wanted to do addiction work. And North Carolina, unfortunately, doesn't have any training programs for psychiatrists wanting to do addiction psychiatry. So I had to leave the state. I had to leave the state and go to the University of Maryland. Did an addiction fellowship up there and worked in Maryland for 4 years before moving to Raleigh. Mm-hmm. And I was trained in both, methadone and opioid treatment programs, mm-hmm. and buprenorphine. Mm-hmm. And I've always done a combination of OBOT, which is office-based opioid treatment, and OTPs, which is opioid treatment programs. Mm-hmm. Both together since 2002. So I've been at it almost 20 years.
Wow.
And when I moved to Raleigh in 2006, I took over Southlight as their medical director. Mm-hmm. And from that experience, I realized there were lots of people driving, hours to get to this clinic. And I'm like, we need to expand. We need to, because we lost a lot of people when, their car breaks down or something happens, they can't make the drive to Raleigh.
Right.
So I started opening new clinics, within an hour or two of Raleigh, mm-hmm. where I knew there wasn't any treatment. And and so I've opened 8 clinics. Wow. And I'm working on my 9th presently.
You coming to Wilmington?
I did think about Wilmington. There are 3 opioid treatment programs in Wilmington. Mm-hmm. But I have thought about going a little further north or a little further south. Mm-hmm. Yeah, there is a huge problem, obviously everywhere.
Yes, there
But
is.
Wilmington is kind of a hotbed of opioid overdoses.
Yeah,
And,
yeah, unfortunately.
that
Now,
that is a statistic that is concerning, but also, to me, that's an area that needs more treatment.
yeah. Now, the
Um,
three that you're talking about would be Wilmington Treatment, Lifeline, and what would be the third one? Or are those two not part of the three you're saying?
so no, so opioid treatment programs are where you come and you dose, as an outpatient daily,
Okay. And that's
and you can
methadone.
get methadone or buprenorphine.
Oh, okay.
So in my opioid treatment programs, we're about 80% methadone, about 20% buprenorphine.
Uh-huh.
So the three in Wilmington are Coastal Horizons.
Yes.
There's a new season, which used to be called Wilmington Treatment Center.
They're going by a new name now?
No, Wilmington. No, not Wilmington Treatment Center. I'm sorry, that's
Okay.
inpatient. Wilmington Metro.
Okay.
And Visions of Hope are the three opioid treatment programs. I believe that Coastal Horizons is a nonprofit,
Mm-hmm.
and they accept Medicaid and Medicare. And I think Visions of Hope accepts Medicaid as well, and I believe Medicare.
Mm-hmm.
And then Wilmington Metro, I think, or it could be New Hanover Metro is what they call it.
Uh-huh.
New Hanover Metro. They take the county name.
Yeah.
And there you have to self-pay.
Mm-hmm. Okay. Now, when I listened, but got to know more about what you do, I watched a YouTube presentation. I think it was from an opioid summit that was perhaps even just in May. Did you do one in May?
May 4th.
Okay.
Yep.
So this is some fresh information. And when I think I went to your website, addiction and sports psychologist. I didn't know that there is such a thing as sports psychology, but I guess it applies.
Sports psychiatry. Yeah. So, absolutely. I have a focus on working with folks who suffer with substance use disorders, and I also have a focus on working with athletes.
Mm-hmm.
And then the overlap, folks who are athletes, competitive athletes,
Right.
and have substance use issues is where I'm at my best.
I see. Okay. I was curious what that connection was. And, I really like so much of what I heard and read about you, Doctor. And the one thing that I put stars and asterisks and exclamation points is when you said that it's very important, the continuity of care after treatment. I think that that's critically important and perhaps underemphasized with some people and or organizations.
Absolutely. We know that addiction, substance use disorders is a chronic medical illness that needs long-term treatment.
Yes.
You might not need, intensive treatment for too long, but there should be follow-up. There should
Absolutely.
be. Our programs really have a responsibility to recognize that this is a chronic illness that needs long-term treatment. And a lot of the detox centers, they do a good job of referring out. And so, and that's appropriate. Their focus is short-term.
Right.
Their focus is the people who are inside their facility. And they do an excellent job of making sure that folks have an appointment before they leave,
Right.
and that appointment is soon after their discharge date. So I don't expect inpatient facilities to really do a lot of continuity of care, but the outpatient providers really should be
Right.
looking at maintaining relationships, even after they're successfully complete the program, there should still be follow-up to make sure they have not returned to use.
Right.
And if so, bring them back.
Right. Right. And that should not be seen as a failure. I've heard it said many times that relapse is part of recovery. And I've interviewed many people that have been in and out for decades, but that you don't know when that next time is going to be. That's going to be, okay, that's it. I just spoke to a woman a week before last that was cured of drug usage, but not of her alcohol addiction. And one day she was going to a meeting, and she had so much anxiety prior to that meeting that she stopped and bought a beer before she went to her meeting, and that was the last time she put her lips to any kind of alcohol. But it was a process. It was years. It was working the AA program. I should probably just call it 12 steps. But it's a different path for everybody. I think there's of course common denominators, but I think that when you get right down to it, everybody becomes addicted, if you will, whether they're predetermined that way genetically and et cetera. But I think also everybody has a different path to recovery, and not everything works for one person that's going to work for the next.
Yes. Yeah, I always like giving a menu of options to someone, no matter where I meet them, what level of care I meet them in. There are lots of treatment options for folks.
Yeah. I'm just looking at my notes here, and I wrote down from looking at your YouTube channel that all levels of care have their place. And
yes,
some require more than others. Some people, I've spoken to people that they just stopped. No meetings, no accountability home or structured living home. They just stopped, and some people can do that. But that's not the norm.
Yeah, that's not the norm.
Yeah. Doc, what is the name of your organization?
The Morse Clinics. So my last name's Morse, M-O-R-S-E.
Mm-hmm.
Yeah.
And website?
morseclinics.com.
That's easy. Okay. And the best phone number for you that I'll repeat a couple times during this interview?
919-676-9699.
9699. Okay. And that goes to one of the clinics, the main switchboard or something?
Well, that actually goes to my office voicemail.
Okay. Yeah, very good. And, I'm just reminded for some reason, last week we interviewed a fellow that specializes in intervention. Any input on that, or are you knowledgeable about that, or is that not within your wheelhouse, as they say?
No. I usually help people with how to encourage loved ones to get into treatment.
Mm-hmm.
Yeah, absolutely.
Yeah, and this fella, he's been at it for not that many years, but boy, sounds like he's got something going on, and anybody can call him anywhere from the country, and he could have somebody at their home within hours. Because as he said, and I'm sure you realize this, when somebody says, they're ready, this is the time, you've got to be able to move quickly. And my wife had the foreknowledge of doing that with one of my sons, and he was very active in his heroin addiction, and it was a very, very difficult time. And my wife, she's pretty sharp this way. She said, we are going to be ready when he says he's ready. And when he said he's ready, well, he wasn't quite as ready as we had hoped, but it eventually worked out. So she knew where to go and how to make it happen, and we very much appreciate that. And something else I learned from listening to you there was a Vivitrol implant that's good for 6 months. Would you like to explain a little bit about Vivitrol and the various options?
So Vivitrol is a trade name. So it's naltrexone.
Okay.
and there is a naltrexone implant that that is kind of a gel beaded technology that dissolves. Usually they put it in your love handle.
Yeah.
And it's from My Life Recovery. Unfortunately, it's not, and it was an organization that I think wanted to do it all themselves and open centers, and they actually opened one in Raleigh. And I think they had about 12 in the United States. They tried to locate them near airports so that people could fly in and get their naltrexone implant and then fly home. And they would, using telemedicine, they would be able to continue their care.
Right.
Counseling. And I don't know if they're still in business or not. I think they still have a center or two in California. But the outcomes that they had, including the one in Raleigh, the outcomes were very, very strong. I think it was like 85% of folks were opioid-free with that implant.
For that 6-month period?
Yes. 6 months later.
Okay.
So I mean, it was an excellent product, but it was really mismanaged, and I'm not sure if it's still available. But I don't know if they still have the patent on it or not.
Okay, so this is not something that the Morse Clinic offers.
No, it's not. Unfortunately, I would love to offer it, but I don't know where it stands with that patent.
I see. Interesting. Now, the naltrexone injection, is that something that you do?
Yes, we do the naltrexone injection. That's good for 4 weeks, and that is Vivitrol, commonly known as Vivitrol.
Right.
I think the challenge with that is you have to be opioid-free for 5 days.
Oh, I see.
And that's a challenge for a lot of my patients to do, unless they go inpatient. So the vast majority of my referrals come from Wilmington Treatment Center, where they detox, they get some clean time, and then they get the Vivitrol shot on discharge, and then they've got 4 weeks to find a provider that can pick up that injection. And so in my private practice at Carolina Performance, I do it. We also, are capable of doing it at the Morse Clinics, the opioid treatment program. But most people choose a doctor in an office as opposed to a clinic for the Vivitrol shot. And really, primary care physicians can do it as well. Any physician can give a Vivitrol shot.
Oh, really? Okay. So
it doesn't require any additional training or experience.
Right, like buprenorphine does.
Yeah, you don't need an X waiver number like buprenorphine.
Yeah, I wanted to bring that up.
Yeah, naltrexone's just a blocker. So anybody can prescribe the pills, the naltrexone pills.
Oh, okay. I didn't know it was available in pill form.
Yeah, it's available in pill form. Extremely inexpensive. Usually you can get 30 pills for like $40. And most people are on somewhere between 1 and 3 pills a day. Okay. And works beautifully. It's an excellent blocker. It reduces cravings.
You have to remember to take it and be consistent, though. So that's one reason the shot's better, I guess.
Yes. The other thing is it can cause a lot of nausea. But the shot doesn't cause
I see.
But the shot doesn't cause any nausea. So that's usually why people will switch from the pill to the shot. They really get a lot of nausea to it.
Okay. And folks, as a reminder, we're speaking with Dr. Morse of the Morse Clinics here on Recovering Hope. If you have any questions for me, please just go to recoveringhope.org, and you can look at our phone numbers or email, or for the Morse Clinic at 919-676-9699. And we're speaking about different medical-assisted treatments for opioid addiction predominantly. And we're talking now about the Vivitrol. Now, the Vivitrol blocks the cravings, is it, for opiates and or alcohol, and also the effectiveness of both of those items. Is that right?
Yeah, so it reduces cravings. It also blocks the euphorogenic effects of opioids or alcohol. So it reduces the drive to drink or the drive to use opioids, but it also blocks the euphorogenic effects. So you can use on top of naltrexone. You can you can drink on top of naltrexone. But what the patients find is that they don't get the benefit from doing it.
Wow.
And so they can kind of taper off themselves. And they learn over time that so long as they take their medicine, naltrexone, that they don't need or want the alcohol or the opioids.
Yeah, well, there was a man, we also run a recovery home here in Wilmington called Prodigal Recovery, and there was a young man there who had his Vivitrol shot, and I also run a little construction company, and he was working for me, and he didn't show up for work, and I called my house. My son was managing the house at the time, and I said, where's Tony? He said, he's out. I said, what happened? He said, tested positive for cocaine. So maybe he thought that somehow he could get away with it, or that would not affect, or that it would prevent somehow the cocaine from showing up on a test. But unfortunately, it did not.
Yeah. Unfortunately, there's not a medicine for cocaine. We've studied all sorts of medicine. There was a cocaine vaccine that looked promising.
Oh, really?
If you use cocaine, you'd get like an allergic reaction to it. And yet nothing has really been shown to be really effective against cocaine. And there's been some small studies using antabuse. So the antabuse is a kind of an aversion therapy treatment for alcohol use disorder. It inhibits an enzyme called alcohol dehydrogenase. And we think that enzyme also is associated in the metabolism of cocaine. So that when you use cocaine, kind of the byproducts build up, and you get a lot more side effects from using cocaine. And so there is some small studies. The problem with antabuse is that it's generic, and so there's no money to be made in marketing antabuse.
Yeah, and that's a problem.
It's hard to get it's hard to get pharma to do the studies.
If they're not going to make any money, right?
Right.
Yeah.
So it really needs to come from like NIDA, the National Institute of Drug Abuse, or SAMHSA, to do the studies on it. So it's a challenge.
Yeah, it is. Do you know anything about, there is, I mentioned this last week as well, apparently there's, I'm just going to read this sentence here, the pharmaceutical industry is looking to bring more non-opioid pain medications into the market, with 17 drugs in late-stage clinical development and 40 drugs in early-stage development. And I'm not even going to try to say these drugs. I'll just spell it for you. One of them is TANEZUMAB, and the other one is FASINUMAB. Have you heard of these things? Do you know if there's some promise for pain medications that won't be addictive or deadly if too much is taken?
It's interesting because if you look at the chronic pain data, some of the medicines that we have that are non-addictive, safe in overdose, these medicines are extremely effective. They don't cause euphorogenic effects that opioids do. And so, for folks who have chronic pain, seek out a good pain doctor. And sometimes the first one you try doesn't work, but the second one does, or the third one does, or the fourth one does. But I do think that because they're really reducing the manufacture and the prescribing of opioids, that there is a need for, newer, better, non-addictive pain relievers. And although I'm not familiar with the two that you spelled out for me, I think that there's a lot of different, ways to attack pain.
Right.
You can aim for the local site. You can aim for the neurons. You can aim for the brain. So there's lots of different ways to modulate pain, and I think that I'm glad to hear that there's that many new products in the pipeline.
Yeah, so was I.
There's definitely a need for that.
Right. And as you indicated before, if it's not, and I'm not trying to be totally cynical here about Purdue and Big Pharma and their motivation, their financial motivation, because if it's not addictive, there may not be as much incentive to put it out there, because they're not going to have repeat customers, which is sad, but I think there's some truth to that.
There is some truth to that.
Yeah.
However, if you find the right medicine that treats your pain, you're going to want to stay on it.
Yeah, true.
I still think that there's a large market out there for new non-opioid pain relievers.
Yeah. Well, hopefully the R&D is being done and these will become available. Let's talk about methadone a second. I kind of liked what you said about that. Part of what I liked is the fact that not only will methadone block the cravings and effects of opiates, but it can also help with the pain issues. I think as opposed to buprenorphine, which we'll speak more about in a few minutes, that's an advantage of the methadone over the buprenorphine. Is that right?
Yes. So methadone is a full agonist. So it has 100% activity on the opioid receptors. And because of that, it works very well for pain. I mean, that's actually its first use when it was developed, in the 30s, 1930s. It was looked at as a very inexpensive way to produce, pain relief, and in a way that was very effective. And so it really is a pain reliever first. And
I say.
Then in the 50s, in New York, it was looked at also for addiction treatment of opioid use disorder, and it was found to be extremely effective in treating opioid use disorder. So, so it's not surprising that it works for, the co-occurring illnesses of opioid use disorder and chronic pain.
Now, methadone in and of itself, I guess, like buprenorphine, is addictive, and you've got to be careful how it's dosed and how much somebody starts with, and to taper them down, right?
Exactly. There is probably both a physiologic dependence that occurs with these medicines, as well as a psychological dependence with these medicines. But because it's so long-acting, it really is a once-a-day medicine. You take your dose in a controlled way in front of a nurse on a daily basis.
Right.
And you don't need to use anything else.
Right.
Because you're stable for at least 24 hours.
Yeah.
And it works really, really well. I mean, our success rate is, nationally for methadone in treating opioid use disorder is about 70 to 80%. And, opioid treatment programs have been around since the 50s.
Yeah.
So, it's 70 years of clinical evidence.
Right.
In fact, SAMHSA a couple of years ago said, we're not going to fund any more studies looking at methadone.
Okay.
Because we know it works.
Uh-huh.
So let's not even study it anymore.
Uh-huh.
So it really is still the gold standard in treating opioid use disorder.
Wow. Now, to my knowledge, the only way to get it is, as you said, you have to go to, let's just call it a clinic or a doctor's office, and take your dose in front of a nurse, but you can't get a prescription for it. You have to go daily, I guess, because of the potential for abuse.
Yeah, the concern is really diversion of the medicine because, one dose that's sold and given to someone who has never taken it before could conceivably kill that person. And that's why the DEA is very strict. It's the highest regulated form of treatment. So an opioid treatment program is reviewed by the DEA, the State Drug Control, the State Opioid Treatment Authority, CSAT, CARF, usually CARF or JACO. I mean, so you've got, and then usually your funding sources will also audit you. So we have audits. We have audits, almost every month we have an audit. So it's really tightly regulated. And the other piece of it is that counseling is really built in. So there's a federal requirement that people who are in an OTP get at least 2 sessions a month of counseling for the first year, and then at least 1 session a month thereafter. And so it's coordinated. So, I mean, I think there's, and then just the structure of having to come to the clinic each morning. Most clinics are only open in the morning.
Right.
And seeing the same faces, and people get to know you. That structure, I think, also is really effective, and why it has such a high success rate.
And I think now that we can tie in buprenorphine along with that with some of my following questions, but would you explain what buprenorphine is and maybe how it's different than the methadone?
Absolutely. So buprenorphine is actually a partial agonist-antagonist. So it has about 30% activity on the receptor, unlike methadone, which has 100%.
Now, when you say on the receptor, you're talking about the